On our morning show today from WRCO, courtesy of the Richland Hospital, we have Dr. James Dickman and Dr. David May talking about Colon Cancer Awareness Month, which is observed in March. They both are practicing at the Richland Hospital, and great to have them in here in the studio today. People are thinking maybe you're here for an intervention with me or something, so I've got two doctors at once. Good to see you guys. Thanks for coming in today. So why is it a special month here, Dr. Dickman?
Well, colon cancer is it is the only cancer that we can screen for before it turns to cancer. And so the evolution of the screening process has happened over a number of decades, and we've seen the colon cancer rates and mortality, death from colon cancer, drop in that time. And so this is a month to proclaim, hey, get your colon cancer screening. This is a way to prevent a cancer from happening. Most screening tests try to catch the cancer when it's early. This is a unique test to try to get it before it even occurs.
Dr. May, do you encourage your patients to get screened?
I do. I encourage them to get screened most commonly at their yearly wellness visit, which is the time set aside to focus on that. And the ages that people kind of are supposed to have the screening is between the ages of 45 and 75, potentially earlier if there's a family member that had colon cancer. But we talk about it. Yep, we check in on that every year. You had your screening done last year, so we can skip it this year. It's not due again for another few years or something like that. But yeah, we check it every visit.
The age has gotten younger, hasn't it? Because it used to be a little bit older than that, 45.
Yeah, that's a new change. I think it was a few years ago, and I think it's because they were seeing we were doing a really good job at detecting and reducing colon cancer deaths in people in their 50s and 60s and 70s, or late 50s maybe. And then it was kind of the 40s and 50s, we were seeing an increase in colon cancers and increase in colon cancer deaths. So they changed it from 50 to 45.
Why do you think that there is an increase, Dr. Dickman, in colon cancer and detection?
Boy, that is a great question. I think if we knew that, we'd be able to be more specific in screening. We do know that it runs in families, and so if you have a primary family member, that means brother, sister, mother, father that had colon cancer, generally the recommendations are age 40 or 10 years before that individual was diagnosed with their cancer. So, for instance, my brother-in-law had colon cancer at age 37. His 3 boys are getting screened at age 27. And as far as specific diets or causes, we really haven't found anything specific, unless, Dr. May, you have an idea about that?
Yeah. I think so. Meats. This is going to hurt Dr. Dickman's feelings because they're maybe all of his favorite foods. But there is associations with many cancers, not even just colon cancer, but animal meats, particularly processed meats, so brats, hot dogs, processed lunch meats. Nitrates is kind of the ingredient that I think is most kind of condemned as an ingredient. And then sugar, so high fructose corn syrup, that is kind of found in sodas and kind of a lot of the kind of sugar, and then diets that are low in fiber. So it's not a huge surprise, but the same kind of foods that lead to diabetes, higher blood pressures, are kind of associated with higher risk of colon cancer. So if you needed one more reason, but they're delicious.
It is. It's hard to avoid those things. But again, like a lot of things, in moderation, right?
Sure. This is, these are not, the studies have a hard time of saying how many brats a week, and then what kind of numeric risk does that give you. But yeah, just to be aware of it.
So take us through the process, Dr. Dickman, of if I'm going in for the colonoscopy, how does that work? What should I prepare for?
such a great question. And this really probably is the most anxiety portion of getting a colonoscopy, is the thought of a clean out. And so we use something called a Miralax prep. It's a prep that is a powdered substance, and you put it in a liquid like Gatorade or Powerade or Crystal Light. I'm okay with individuals even using just water. And it's about a half gallon. And so 5 days before your procedure, you try to stay away from roughage type of foods, corns, pea pods, cucumber skins, potato skins. These are things that we normally recommend that you should stay on, but for a colonoscopy prep, they run the risk of clogging up the scope. And so then the day before, you're on a liquid diet, and then you start the prep. We have options of if drinking that amount all at once is problematic, it makes an individual nauseous, of splitting the prep up. So you drink half of it the night before and half of it in the middle of the night, and usually we have a really good result by the time your colonoscopy comes around. There's also 4 little tablets that help the colon get ready to move that process, move all that fluid through. And so I have to say that by far the majority of people, when they get into the hospital and they're getting ready to have their procedure, I ask them how it goes, and by far the majority say, oh, it wasn't near as bad as I thought it would be. We're always trying to tweak the recipe to make it a little bit more patient-friendly, and so every few years we try to modify it a little bit or give different options. Of course, there's the old standard of go lightly. That's a whole gallon of a salty type of mixture. And for people who have had multiple colonoscopies years ago, that's something that was used. And I can say comparatively, most people love the Miralax prep.
Mm-hmm. So how often or how long should I take off work? Obviously, that day. Is it common to take the day after, Dr. May?
Nope, you should just need the day. Even the day of your quote-unquote prep, depending on the hours that you work, I think Dr. Dickman and I both have had colonoscopies. He told me I could say so. We worked in the clinic until 4 or 5 o'clock that day, and then you can kind of start your prep right about that time. So in the evening, and then it kind of carries into the 9, 10 o'clock area. And then the next day is when you have your procedure, and that's the day that really you need to miss.
So you both had them, and you knew what to expect, but were you a little nervous going into it or not? How do you look at it?
I was not. I was more nervous about that. You do get an IV. Then our nurses in the outpatient department are fantastic about being good at it on the first stick, and that wasn't a big deal, really. I mean, I may be a little biased because I do them all the time, but it was a really easy, straightforward, pleasant procedure.
Mm-hmm. What about you, Dr. May?
Yeah, I would agree with that. I had no, I've done them, obviously, so I know what was going to be happening to me. I was more just worried about anything that would be found,
Mm-hmm.
which I think is pretty common. You're about to, it's just like, I'm going to go get this x-ray, or I'm going to have a mammogram, or any other kind of, I'm going to get my cholesterol checked. I hope it's good. I hope I'm healthy kind of thing. It was just that kind of anxiety.
How often do you find something that's out of the ordinary with a colonoscopy? Very often?
Well, we keep statistics on that. There are national benchmarks, and generally about a third of patients in general will have a precancer polyp, and it really is surgeon dependent on how well they find. And I'm pleased to say that all of our surgeons, we have our 2 general surgeons, Dr. Loomy and Dr. Gilbertson, as well as Dr. May and myself, are all above the benchmark in trying in finding them and removing them. So we generally find them in about 40% of our patients. And I think there may be a demographic, maybe southern Wisconsin just makes more of them. maybe like Dr. May states, that we're really good about eating charcoaled brats and steaks, and it's maybe not the best, but boy, it's so good.
This is a process, Dr. Bay, that you take care of it, and you don't have to like make another appointment and come back for the procedure. It's one fell swoop, isn't it?
Yes, one fell swoop most of the time. I think, it's a polyp, or even a small abnormal polyp, generally takes about 10 years to turn into a cancer. So it's in there and kind of slowly growing over years. And so most of the polyps that we find are small, like a pencil eraser at the tip of a pencil or smaller. And so these are kind of years away from being cancers in the majority of the time. And those we remove during the procedure. If there was a bigger polyp, maybe the size of a thumb, we can handle removing those during it as well. Sometimes you get a polyp, or even it starts to become more of a mass, the size of a golf ball or a plum. It's harder to remove the whole thing without running the risk of damaging the colon. But that is rare. I mean, very rare that's happening. Less than 1% of the time, I would guess.
So I'll pose this question to you. We see the ads all the time about screening, where you mail a sample away and you get detected. How accurate are those generally?
Go ahead.
You can go ahead, Dr. Dickman.
Okay. So yes, we've seen those ads, and it is absolutely a way to check for colon cancer. It's a much better test if you already have colon cancer. It does pick up the polyps that lead to colon cancer, although the accuracy goes down the smaller the polyp is, and I suppose because there's less cells to find in that sample. There is a false positive and false negative rate. The false positive rate is about 15 to 17%, depending on what study you look at. So that means it shows up positive, it causes some anxiety. People then have to get their colonoscopy done anyways, and then 15% of those, after doing a really thorough exam, we don't find what would trigger that. And that is an interesting concept. We don't really know what causes those false positives. Maybe it's a little blood from a hemorrhoid or from a little blood vessel in the GI tract. But I will tell you this: if you did get a colonoscopy because of a Cologuard and we didn't find anything, then you're on the 10-year follow-up. And so, we want to be sure that we get you an accurate test, that it's reliable, that you have appropriate follow-up, so that we can take that anxiety of what's going on off your plate.
Mm-hmm. Certainly better than nothing, though, right, Dr. May?
Yes. And I would say, in medicine, we have one-on-one patient interactions, and so you have to kind of be focused on the patient and what is best for that patient and what are they willing to do. But then I think nationally or even globally, we have to start thinking like, what is best for everyone? And there are an enormous number of people who go through life never completing a colonoscopy because they don't have access, because the waits are enormous and they're waiting for months, because they're scared. So I think there's a huge barrier in a lot of places to getting a colonoscopy, and Cologuard is, it's much cheaper than a colonoscopy. It needs to be done every 3 years, and it is pretty good. It doesn't. The statistics and the studies would show that it doesn't miss a lot of cancers. Okay, so if you are really good about doing a Cologuard every 3 years and it is always negative, the risk of you dying from colon cancer is actually very low. But there are, pitfalls. A false positive, a positive when it shouldn't have been positive, that would be caught with a colonoscopy. And then, Cologuard's thing, Cologuard is proprietary, and there are other competitors with it. Cologuard happens to be made in medicine, so it's the one we use most around here. But it's just a DNA sample of stool. but I think they're very good about saying, if you've ever had a polyp, don't do this. If you've ever had a positive, you're kicked out. You shouldn't do those anymore. If you're high risk because of a family history, you shouldn't do these. If you're having symptoms, crampy, changes in poops or blood, this test isn't the right thing for you. So there's kind of a lot of caveats on the Cologuard, but I do think it opens the door for an enormous number of people all across the United States, certainly, to get screening.
With the family history, should you get more regularly then, more on a yearly basis, or how do you look at it?
So a family history in a first-degree relative, so mom, dad, brother, or sister, one of those folks would put you in an every colonoscopy every 5 years. Okay. And generally you start 10 years before the age that person was diagnosed. Extended family carries less risk, but if there's two extended relatives on the same side, so maybe kind of my mom's mom and my mom's sister, my aunt and my grandma, then that would also increase your risk similarly every 5 years.
Is it true, Dr. Dickman, that a lot of times people don't have any symptoms, when they have a problem?
Absolutely. The vast majority of individuals that we find colon cancers in do not have any symptoms. No rectal bleeding, no change in bowel habits. There are some that do, and so I would hope that their relationship with their primary provider is solid enough that if they have concerns, that they would come in and just talk about it. What would be the next step? What would be causing these changes in symptoms? But the majority of symptoms, and over the last 4 weeks, I've diagnosed 2 colon cancers, and both of them were asymptomatic. They didn't know that they were in there. So we're in the process of getting those taken care of.
Mm-hmm. But like anything, early detection is the key, isn't it?
It is, which is why we have these screening programs at age 45. And if you have no risk factors, no polyps, then the next one would be 55. Same thing until we hit 75.
Mm-hmm. So let me ask you this. We'll switch gears just a little bit, but has it been a rough winter? As it seems like a lot of sickness out there in the community. Are we over the hump or not?
Yes, we are. I'm a positive guy.
Good. I like that.
I think we've seen the last week urgent care numbers kind of become less as far as the upper respiratory tract symptoms are. We had a nice surge of influenza A, and then a lot of cough for weeks after people have recovered. They just had this nagging cough. But there's been a little bump in mild COVID. But I think we're getting there, and certainly the weather helps.
Yeah, getting outside and getting some nice fresh air, right?
Yes, and I tend to be a pessimist, I think, is why Dr. Dickman emphasized the optimism. But I would agree with him. I think we're on the downslope of acute respiratory diseases for the winter, though there is some stomach, GI, vomiting, and diarrhea illnesses. So your best protection is hand washing. Don't forget your hand washing.
Right, exactly. And as a physician, it's kind of an exciting time, I think, to be in medicine, isn't it? I mean, there are a lot of advancements. It seems like every year that goes by, something new comes along and maybe is better.
Oh, for sure. Sometimes it's difficult to keep up. So, I'm blessed with great partners that have different interests, and we have dialogues all the time about what is new, what is something that we haven't seen before, the Richland Hospital and clinics are really blessed to have good nurse practitioners and physicians, as well as subspecialists like orthopedics, general surgery, to just make us a well-oiled team.
Mm-hmm. How long have you been a member of the staff here?
I'm coming on 23 years.
23 years. And you, Dr. May?
I started in the fall of 2009.
Okay.
So I guess coming on, 15 and a half years.
Uh-huh. So what are some advantages? What do you like about being a physician here in the community?
I actually like bumping into my patients out and about in the community, whether it's kind of in the local soccer leagues or out and about at school functions, or even kind of at the grocery store. I kind of like being a part of the community where I'm practicing.
So you don't get somebody, hey, look at this mole, Dr. May. Do you get that or not?
Sometimes I get that, and that's fine. I'll look at it and say, why don't you stop in the office where we can have more of a private conversation about it.
What about you, Dr. Dickman?
Yeah, I think just the ability to help. I just want to help. I think that is a common type of goal and feeling with all of our providers. They just want to help, and we have a really excellent system on making that help a reality. And so if we can't find your answer here, we have resources outside of Richland Center that are easy to get to. It's really an exciting time to be into medicine.
Yeah, and I think so too. With you got the telehealth, right? That you can use and utilize that as well. Something that we didn't have that many years ago.
It's true, yeah, and we have an excellent relationship with the University of Wisconsin. We have their specialists come out here. It's an easy phone call to just ask an opinion about what might need to happen next in any particular case, and our provider base in Richland Center has just an incredible experience of dealing with patients and what plagues them.
You both are on a billboard, so you're famous this month. It seems like, right?
I had to mention that.
I saw you. Hey, I know those guys.
We anticipate it's going to be a huge draw for people getting their colonoscopies.
We've already contacted State Highway Patrol to see if the accident rate just past the billboard goes up.
It could.
We'll tear it down if that happens.
I don't think so. Anything else you'd like to add about this month, or anything else?
No, I think Dr. Mays just hit it on the head that the yearly physical is a fantastic time to talk about it. All of our primary providers are trained that this is a part of the dialogue that happens at a yearly physical. But anytime anyone has any concerns, it is just a simple appointment to talk about it with hopefully someone you trust and can address those concerns and be able to say, okay, here's what we're going to deal with them.
And Dr. May, just encourage people to get their colonoscopies, right?
Yeah, I think colon cancer screening and all cancer screenings. I mean, preventative health is the best health. I mean, I think that's for a lot of us in family medicine that's what we believe in. That's what we like, and it's not always glamorous, but it's the day in, day out, keeping yourself healthy.
Thanks for taking time out of your busy schedules to come in and join us today.
Thank you, Phil.
It's important.
Yeah, thank you so much. Appreciate it.
You bet. Dr. Jamie Dickman and Dr. David May joining us here on The Morning Show. This portion here today, again, Colon Cancer Awareness Month is observed in March.